To lead our discussion today, I'd love to introduce you to the session moderator, Connie Montgomery. Connie was educated at Francis Marion University and the Medical University of South Carolina. She works closely with three groups within the National Hemophilia Foundation: the Steps for Living Task Force, Annual Conference Planning Committee, and the Cultural Diversity Working Group. She also serves with the NHF Speakers Bureau. Connie has served on countless boards and is the charitable campaign chair for Inspiration Foundation, a 501c3 nonprofit organization that helps patients and families with chronic rare disorders receive educational, community, and financial support. She's been featured in national magazines like Hemo Aware for her work and her advocacy on issues of women with bleeding disorders, healthcare disparities, diversity and inclusion, and the importance of authentic communication in the healthcare setting. And now I will turn it over to Connie. Thank you so much for joining us.
Welcome all to the session entitled The Intersection with Race, Ethnicity, and Equity with Diagnosis and Treatment Access. Today we have Laura Bloom here, and we're going to have Laura introduce herself momentarily and Dion Stalling. First, we will begin with Laura. Please introduce yourself and tell us a little bit about you.
Hi everyone, my name is Laura Bloom and I am the President and CEO of the Ehlers-Danlos Society, which is the global organisation looking after people with Ehlers-Danlos syndromes and hypermobility spectrum disorders and all the associated symptoms and conditions. I'm also an academic affiliate professor of practice in global collaboration and patient engagement at Penn State in the US.
Thank you so much, Laura. And Dion?
Hi, my name is Dion Stalling. I'm the founder and executive director of Rare and Black, whose mission is to amplify the voices of Black people and caretakers in the rare disease space.
My name is Connie Montgomery. I'm from South Carolina. I've been diagnosed with factor VII deficiency and pemphigus vulgaris. For many years, I was not properly diagnosed nor received treatment, even though all the symptoms were present all throughout my life, from childhood to through adolescence and my teenage years to young adulthood. It took running a car accident in my mid 30s to get proper diagnosis, even though I am a healthcare professional, retired now. At the time, I was an occupational therapist doing traveling occupational therapy around the rural parts of South Carolina, yet didn't have a proper diagnosis of rare factor VII deficiency. But the car accident led to a proper diagnosis because we happened to have a doctor in the ED, the emergency department that day, that knew that something was absolutely wrong because I kept bleeding and bleeding, and had a PT done, a prothrombin time, and a PTT done, and a hematologist consult, which led to me getting a proper diagnosis of factor VII deficiency. But for many years, I lived through epitaxis and having to leave out of the classroom as a girl and run to the bathroom and use all the tissue and the paper towel and everything I could find in there to try to stop the bleeding and then to clean up everything. Always bled through all of my clothing with my menses and always wore just tried to always keep an extra set of clothing and just went through a whole lot. And even though culturally the way I was reared was what happened in the home stays in the home, my mother and I discreetly tried to share with the physicians at the time what was going on with me. None of them really listened. So it led to severely delayed diagnosis and a lot of struggles. And I suffered silently with factor VII deficiency for many, many years without proper diagnosis. But in saying that, it helped me learn to advocate for myself once I attended a conference in about 2011. The National Hemophilia Foundation had an annual conference, and I went to that conference, learned a lot about my diagnosis and seeing other people out in the hemophilia community speak about their particular diagnoses. Even though there wasn't a lot of people with rare bleeding disorders there, like factor VII, then there's factor V and factor 13 and factor 10. Um, I was just amongst people that I saw able to share. And I learned a lot from those ladies and gentlemen there. And I learned how to advocate and share my condition. And so that's my a bit of my rare journey. We are delighted to have both ladies here today to talk with us a little bit. And we're going to start with Miss Dion. The first question I have for you today is please share with us some information about your individual rare healthcare journey to this point regarding the road to accurate diagnosis and treatment access in your community for your rare disorder.
It's been a long road. I have uh, four rare diseases, but the one that has the most impact on me is primary immune deficiency. I had a lifetime of infections, different illnesses, and some of those illnesses snowballed into other things. And so I finally, after having MRSA and staph together, I had an infectious disease doctor that was committed to trying to figure out what was wrong with me. You know, why were things happening to me surgically that couldn't be explained? And in 2014, I was diagnosed after 7 minutes with a immunologist. Every question that she asked me was yes. Every time she said something, I said yes. And so she said, let's do a vaccine challenge, which is, you take a pneumonia shot, and within 24 hours, you have to go back and get your blood drawn. And that was on a Thursday. And Tuesday morning, she called me and told me what I had. And that was relief, anger, and it was just really overwhelming. That time, by that time that I was diagnosed, I had other things. So now I have short bowel syndrome as a result of infections, because I had infection that you wouldn't have been able to see unless you opened my abdomen up. And that's happened twice. And so each time they had to take part of my digestive system out, amongst other organs. And so that is that piece. And it's every day it's been a fight for other things. And it's, like I said, it's snowballed into other areas, other systems of the body, my nervous system. I have a vestibular disorder as well. And those things affect other activities in your life. Like I'm a spoonie. So if I do something today that's kind of strenuous, if I can, it's going to take me about 5 days to recover. And also I have peripheral neuropathy, which is usually the damage that I have. My doctor had told me that, this is something that normally happens to diabetics or people that have taken chemotherapy, which I've done neither. So I'm thankful that it's brought me to this time. I do sub-Q infusions at home weekly, and I do a lot of work with plasma donations, the plasma donation community, trying to let people know how important plasma donation is, as well as newborn screening.
Dion, you are rare and resilient. Thank you so much for sharing with us just a bit of your story and your healthcare journey to this point.
Thank you.
Now, Lara, can we hear from you?
Absolutely. So I have Ehlers-Danlos syndrome, and I was symptomatic from the age of about 11. But it's thought that I was born with it. We don't know yet what the genetic causation is behind the type that I have. So it's believed that it is genetic, as with all of the other types of EDS. And I didn't get diagnosed until I was 24. So I had the average kind of 13-year diagnostic odyssey that many, many people living with rare and chronic conditions have. And growing up through school, when puberty kicks in, when your teenage years kicks in, is often when people are most symptomatic, and that was true of me as well. I had a few things that are textbook with EDS, and I had a few things that were unusual. So, for example, I fractured both my wrists over 20 times, and actually bones aren't really affected with this type of EDS that I have. But it was all of the tissues around the bones were so fragile that the bones were kind of just bouncing against each other. And so I had to have both my wrists fused in my early 20s, and that was pre-diagnosis. So that happened to both my wrists, and no one questioned why. I was told that I was unlucky, and accident prone, hypochondriac at times. You know, when I used to go into hospital with recurrent fractures, they gave my parents that look, and you know, on more than one occasion they were questioned. And I think in addition to growing up with a rare condition, I was also growing up struggling with my sexuality. And I was, you know, a 15-year-old girl who cut their hair and wore trousers instead of skirts. So when I presented at the doctor, I was told I just had anxiety and depression and going through what I was going through. And it was a lot of unconscious bias and judgment that was throughout the years that I was waiting for my diagnosis. And when I was finally diagnosed, it was by a dietitian who, for the first time, brought all of my symptoms together and didn't look at it all in silos, and thought that I had something called Marfan syndrome, which is another connective tissue condition. But it got me to the genetics clinic that specialized in connective tissue conditions, and I was then diagnosed with EDS. So it was a long journey, but that day of diagnosis for me was a big relief, because it finally gave me the answers to the many questions I'd had over the years.
Laura, thank you so much for sharing with us a bit of your story. So today, we all share the fact that it took a good little while for us to get proper diagnosis for our health conditions, especially our rare health conditions. But we're forging forward. What does health equity mean to you, Laura?
I think the heart of our mission at the Society is to get to a point where geography and wealth doesn't determine your quality of life. And too often, everywhere around the world, we're seeing people don't have access. The healthcare systems everywhere, even in places like the US, Europe, are set up for the acute, not the chronic. And so everything is thought short term. Things like physical therapies, mental health therapies to help you living with that kind of diagnosis. It's all kind of given to you with a month or two. And there's rare examples, but they usually come with you being able to have to pay for the privilege. And it then means that we do not have an equitable situation around the world for people living with these conditions. What we often see, for example, in the UK is we have a fantastic NHS system, which if you're dying or you'll get hit by a car, or even if you have cancer, then you're going to be looked after incredibly well. However, if you have something like EDS, you really are neglected in the sense that there aren't that many experts. Most people wait a really long time to see one, and then they're kind of thrown back to the wilderness of their local care services, and they're not given the help that they need. I think across all rare conditions, when people are diagnosed, they're not given the psychological support as well as the physical support. I think when you're given a diagnosis, even if you choose to not have it, you should be offered the support that will allow you to adjust and learn to live with this thing that's going to impact you for the rest of your life. And it's rarely not given, not as a given. It's not there as a pathway, and it really should be. So to me, equity means that we have to realize that everyone is different. People require different things, but the objective for all has to be early diagnosis and long-term management and care of both the physical, the emotional, and the psychological, because all are a bridge to each other.
Thank you so much, Laura, for sharing that with us. And Dion, what does health equity mean to you?
Oh, health equity for me would be access. Also, going back to mirroring off of what Laura said, access to treatment, but also I want to touch on the Burton-Hill Act in the United States in 1946, with the government was the idea was to have healthcare systems built off of that. It was kind of the beginning of redlining. And so I say this because when I got diagnosed, it was because a doctor that I had been seeing for years wouldn't operate on me, and other surgeons don't go behind other surgeons. They tell you to go back to your original surgeon. If you're having a problem for surgery, they tell you to go back. Well, he wouldn't open me up. So where I lived, there was a hospital a mile away from my home. And this happens, I've heard this story a few times as I've been speaking with to other organizations. You know how people come behind after a conference or something and talk to you. Health equity should not be for people that, it's not just a socioeconomical thing. Sometimes it's proximity. I live less than a mile away from a hospital, but my treatment is 26 miles from my home. I bypass 4 hospitals. St. Louis is the home of one of the best hospitals in the country. And so I've been talking to some of the professors, because what also needs to happen, you can have the treatment and the access, but if you don't have doctors who listen and not prejudge you, like Laura was saying, people have their own biases. All of us have been called hypochondriacs or told that we were mentally ill, you're suffering from severe anxiety or depression because you physically have something wrong with you. That should not be a deterrent for you to get treatment, access. Medicaid expansion is a thing. You know, there is a number of things, but also not just Medicaid expansion. People that make it so that our healthcare systems needs to be in a place where everyone can get the same medicine at the same cost. It doesn't matter what type of insurance you have. And so being equitable would encompass all of those things, but also have a financial and a mental health component attached to it.
So I hear both of you sharing a bit that comprehensive care is going to need to be in place for folk like us with rare disorders, but with folk who are in it for the long haul, chronic disorders. And I also hear both of you sharing a bit that we need to take on more of compassionate healthcare and looking at the human condition of each individual and how unique each situation may be. Is that correct, Laura?
Yes, I think so. I think that too often people are thought of broadly, and people don't take into consideration where people live, what has led them up to that point, the support that they have around them. It all impacts as to what their outcome and quality of life is going to be. And so people need to be treated as individuals, but the kind of overarching concepts need to be in place. And for me, that really does, again, go back to thinking about long term. You know, these are conditions that are there for life, and it has to be done through a lens where you are taking in a fully kind of multidisciplined, multi-systemic framework, and you're ensuring that that support is there no matter geographically where someone lives. And also for an organization such as ours, that we're thinking about global, all the different nuances around the world that people face. In the US, for example, it's health insurance. You know, in the UK, you've got the NHS, and then people can pay. And in places like South Africa, you've got a handful of geneticists across the whole country. You're just not even going to get to see anyone to get that diagnosis. So where do you begin with getting that equity in place? So yeah, there's an abundance of issues still that face the rare community. There really are, and there's great efforts going to trying to equal out things. But I think if we start to think about the individual, we're definitely on the right track.
Thank you, Lara. So, Dion, how has being an individual with your specific rare health disorders led you to the type of work and service you currently provide?
Okay, Rare and Black was born out of that service. I started to get invited to speak. Also a volunteer for the Immune Deficiency Foundation, because that was my immune deficiency was the biggest catalyst that threw me into chronic disease. So I felt as though I wanted to know more about the disease, and what better way is to get involved with the premier organization that handles it. And so I hold 4 different volunteer titles there. So legislation, and then I go to doctors' offices to pass out pamphlets and to teach them about the organization as it pertains to support um, for patients who are newly diagnosed. And and when I was speaking, I would get invited to plasma donation, not plasma donation, plasma making organizations, because that's our treatment. And what I found is when I would go to a group of people, I was usually the only person of color. Well, I was the only person of color. And I've been asked different things, why do you think that people of color or Black people have not been diagnosed? I didn't get diagnosed until I was 45. And if I did not have the doctors that I had, I still wouldn't have been diagnosed. I am convinced that my tenacity and persistence of trying to get out of the hospital system that I was in, that it led me to the hospital that I'm in now. So all of my doctors are there. But the work that I do with Rare and Black, it started with me just talking to medical school students, because I honestly believe that if we can change the way that the medical doctors think, and how medicine treats people that come in over and over and over again for things that are not textbook, but because we're not textbook people, that if I can catch them in medical school with the curriculum that I taught for a workshop, then you know how you were in 3rd grade and you remember this lady coming in with this fantastic career, and it's like, I remember that. You still remember those things 30 years later because it made an impact. So usually when I tell my story, that's very, very long, hopefully it will change the trajectory of someone's opinion about how we are as chronic. Most of us are chronically ill, not all of us, but most of us. But I feel that if we can get them in the medical school setting, then maybe we can change when they go out into practice and be able to remember, or even dig deeper and be more inquisitive on why certain things are happening, and not just because it was in a book. And so that's how Rare and Black was created. And also we're doing an initiative that in the rare disease space, there is ageism. Usually parents are fighting for their babies. There's nothing more forceful than a mom that's fighting for her children. But for someone like me at 45, it's like I had to fight for myself. But there are also other people with my same illness that don't get diagnosed until well into their 60s or 70s. And so something needs to be done about that. So that's the reason that I do the work that I do.
Well, we thank you, Dion, and you made some wonderful points. Absolutely appreciate all that you just shared with us. Now, Laura, how does the work that you do affect overall healthcare diversity, equity, and inclusion in your community and in our overall global world?
So I think this last year and a half has been monumental in so many ways to so many of us. And before the Black Lives Matter protests, the society realized how there needed to be so much more effort into making access more equitable. And so in January 2019 we actually launched our Breaking Down Barriers campaign. And the idea of this campaign was to hear from the community directly as to what they perceived and believed and it had experienced to be the barriers that they were facing from all over the world to getting that access to a diagnosis, to management, and to care. And critically, that one other piece that I think is so important, to validation, because so many people are disbelieved and not taken seriously, and that has such an impact on people's quality of life and their mental health, and it has so many repercussions, and it is so important to feel validated. And that happens from the minute they call the doctor's office and speak to the receptionist to book the appointment. You know, people don't realize the language, the tone people use that makes people feel dismissed and not believed. And it goes all the way through to their long-term care. So we actually are very proud to have something called EDS Echo, and Echo was launched out of Project Echo, which was put in place to help educate and telementor people with hepatitis C, and it was so successful that it's rolled out to lots of different conditions all over the world. And EDS was actually the first ever rare echo. And so we now have EDS Echo across the world for different disciplines. And the idea is to educate, and not just educate the medical side of things, but to really educate on language, on how to speak to patients, and really make people feel believed and understood and listened to. Because something like EDS, where there isn't any drugs approved by the FDA for EDS, for hypermobile EDS, for any of the types at the moment, there isn't a cure, you know. So we're not, all the other pieces are what really help people to feel supported. And yes, there's a lot of things that can improve quality of life, but getting that right is so important, and you can't get that right without listening to the community directly. We also ensure that on any kind of collaborative research group that we facilitate, we have the patient voice in all of them, because without the patient narrative, it's a redundant exercise, and it has to be brought in at the beginning, and the patient has to be an equal stakeholder in every way, and that's extremely important to us. So we're working hard to ensure that we are really emphasizing the importance of the community's voice in making those changes, and then thinking about ways that we as an organization can help facilitate that change.
That's amazing. Thank you so much for sharing with us, Laura, all that you and your organization are doing. Now, I have one last question for both of you women, and I want you guys to just take some time and think on this, and share with us what you can regarding your solutions to some of the barriers that we see in the rare community. What are some solutions and some things that we can put in place based on our own personal lived experiences that would aid in making some changes so far as it aligns with healthcare equity? I'll start with you, Dion. What are some things we can put in place based on our lived experiences that would help others in the rare community with healthcare
Well, the
equity?
first thing, Rare Disease Week is next month. It's virtual again this year. I would tell you that if you have a story, and I believe everybody has a story to tell, to get involved with Rare Disease Week with RDLA. I forget Rare. I can't remember what it's called, but it could be Googled. But excuse me, get involved, because going to Capitol Hill and telling your legislators your stories, I believe works. A lot of what we do hinges on legislation, whether it be Medicaid expansion, Medicare, because a lot of rare patients are totally disabled or partially disabled where they cannot function to do a job every day. Excuse me. So I would tell that would be the first thing. The second thing is I believe that while Black Lives Matter, the movement brought diversity, equity, and inclusion to the forefront, it's not good enough to just have a Black person on a board, or just for the sake of having them on the board to show them, hey, I have a Black person on this advisory board. Really ask questions to the people that you're servicing, the small pharmaceutical companies, large pharma, need to be able to be held accountable. I would tell people, write letters. Letters are good. If there's something in your treatment, this is an example. A young lady lost her insurance, and so she couldn't take her medicine. We have medicine that's made from blood plasma, and it's a long way of how it's made. It's not instant, like it's not a pill made. There's times, And so she couldn't afford Cobra, and she didn't qualify for Medicaid because in our state, unless you're pregnant or legally disabled, you're not eligible for Medicaid. And so she went a whole year without treatment and she died. That should not happen in this country. And so as you hear people having stories like that, if Laura calls me and says, "Hey, Dion, I know someone, this happened to them. They have a PI, primary immune deficiency. What can I do in your state?" If there's something that you don't have to be affected by this to raise your voice. You can call your legislators. You can email the CEO of who makes the medication. Let me contact their CEO. The secretary will get the email, but it'll be read. And so we need to be more mindful that we as patients, sometimes we can't fight for ourselves. It's exhausting being a rare disease patient. Some people don't have support. I thank God that I have the support that I do, but a lot of people don't. And so you can advocate on their behalf just because they're another human being. We should not sit by and be idle, given whatever diagnosis we've been given. And also, we should not be afraid. If there's something that's not sitting well with you, and your doctor tells you you need to do this, if the treatment is not working or you're not improving, you have the right to get a second and a third opinion. You have that right. And we should not be okay with, oh, well, the doctor went to school for 16 years, so he must know. No, they're human. They forget things. Second opinions are just like my perspective is different than yours. And so if you get another doctor, maybe he's seen someone with the same symptoms and he's seen 20,000 people, but you're the one that he remembers he had another one. You shouldn't be idle in your treatment. And even though I've been sick off and on all of my life, if there's something that I don't like with my doctors, I let them know. No, I'm not going to do that. And let that be part of your chart. Just like I went to the doctor last week and he was like, "Are you a new doctor? Are you going to take this medicine?" I said, "Yeah, if it works. But if it doesn't work, I'm not going to take it." You have to tell them and not be intimidated. And there's a whole health literacy thing that we have to get over. I know a lot of communities. There's a woman that I met online that does interpretation. Her organization does interpretations for rare diseases for Hispanics. We have to also know that there's a health literacy piece that is missing from the rare disease space because it's a lot. I don't know what Ehlers-Danlos is, but Laura said that there's different types. So when a doctor is talking to a patient, they need to explain in layman's terms, not just the name of it, but this is what you should do. And so this goes back to my work. I would love, my mentor asked me this a couple of weeks ago, what ideally would I like? Ideally, I would like for every major hospital in every metropolitan city to have a rare disease office where you can go to get information about Rare and Black, the Ehlers-Danlos Society, immune deficiency, because there's nowhere for people to go other than the internet. And we know that the internet, once you get on this, then you go to a diagnosis website. That's not good because you're rare. Your symptoms are not going to always be there. And so we have to be mindful that we do have conditions that are not textbook, that we shouldn't be complacent in our treatment. If you've taken a medicine for 2 years and it's no longer working, but you take it anyway because this is what the doctor said, you have to be, and if you cannot remember, if you feel as though you don't see your doctor for 3 months, but you're having a symptom now, everyone has a phone and everyone has pen and paper. Write this down. This happened to me on this day. And if he doesn't listen or she doesn't listen, then find another physician that will, because there are some really good physicians out here. You just have to get through the ones that are not for you.
Thank you so much, Dion. You made some wonderful points there. Get involved, share your story, ask questions of those being serviced, write letters, raise your voice. Outstanding. We appreciate each one of those. Now, Laura, same question for yourself. As we are wrapping up this intersection with race, ethnicity, equity, diagnosis, and treatment access, with the triumphs and the barriers and the trials we see in the rare disorders community. Your lived experience. What are some solutions and some suggestions you have for us, Laura?
Well, firstly, I echo everything Dion said. I mean, I think for me, I'm going to suggest something slightly different and thinking about research. So, I think firstly, what I would say is when it comes to anything, if you put on your diversity and inclusion glasses and look at everything through that lens, everything that you do, everything that you say, every event, every program, you're going to be winning. You're going to be helping to represent everyone and make those changes. When it comes to research, there is definitely a racial bias in research, certainly for Ehlers-Danlos syndromes, and I'm sure across rare diseases more broadly. Let's talk about that. Let's not shy away from it. Let's not just see it and say that's what's going on. How can we change that? How can we get more representation into published research? That's number one. So we're proactively working with our research community in ways that we can do that. And the second one is, throughout this wonderful virtual world we've all been living in the past, year and a half almost, we are doing more and more virtual conferences. And so more and more people have access to attend. And you're seeing lots of fantastic PowerPoints. And every single time, on the whole, that we see an example of skin in Ehlers-Danlos syndrome, it's white skin. Why is that? Because there is no racial bias in terms of who gets affected with this. We need to see better representation on visuals, slides, examples of skin tearing, skin fragility, skin thinness. I'm giving EDS as an example, but I'm sure there's lots of examples in different conditions. And so we facilitate the work of the International Symposium. We have about 160 people in there, which is all disciplines from all across the world and patient experts within each working group. And we're sent an email out to say, we want better representation. Please, can you send us more examples that really do represent a diversity in skin color, skin texture, age, gender, all of these things, because you just tend to see the same representation. So it's things like that. Change it systemically, change the root cause, the papers the doctors are going to read, the PowerPoint presentations people are going to watch, and then it will trickle down to the community and really start to make that change. So there's lots that can be done. And I'm excited that we're living in a time where people are really realizing that they can make that change too.
In our communities now, yes, there's a spotlight on healthcare disparities because the pandemic brought forth and put a spotlight on the fact that there's so many marginalized communities not getting the type of treatment and the care that they need. But we in the rare bleeding disorders community have had the lived experience of delayed diagnoses, as I just shared, and sometimes difficult treatment access, and a long healthcare diagnosis odyssey just to get a proper diagnosis. How do you think the members of our rare disorders community can sort of help forth communities, especially the marginalized communities, that are experiencing these healthcare disparities, being that we've seen so many struggles and suffered silently ourselves? How can we best support and help those efforts? I'm going to start with Laura. Laura, how can we do that?
I think Dion touched on it earlier. For me, the best way to do this as individuals, as organizations, is to share your voice, to share your story and your experience, because without that, we're not going to get across what it feels like to be a young Black woman living in Africa with a rare disease, unable to get a diagnosis, or a young white man in the UK who lives in, the Highlands in Scotland with no one around him that can diagnose his rare condition. It's the narrative, it's the community voices that is really going to share these stories and help make change. And when you think about what that change will lead to, you hope it leads to the, medical professionals taking up the rare cause and treating and being willing to specialize in these areas. And I think it's really hard educating medical professionals. It's not impossible. But what's even harder is re-educating medical professions for what they think they know. And that is something that I think is incredibly important, because there is this unconscious bias, especially when it comes to the young white woman who is always labeled with anxiety and depression. You see that a lot in rare disease, and you see it a lot with Black women as well, much more than you do men. We always get asked, why is so many more women living with EDS than men? And there's no scientific reason for it. There's no gender bias for EDS. It's that it could be hormones. It could be that women go to the doctor more than men, but it's not because women are anxious and depressed. That's not what's happening here. And so I think that we really need to think about that. So I think by sharing people's stories, their diagnostic journeys, their outcomes, how much better their quality of life is once they get that diagnosis and management and care, or not, what barriers are preventing them from getting that. I think people don't understand why there are racial disparities in healthcare. People think, why, if you're not white, does that mean you can't have access? And people are confused by that. And I don't think it's being racist. I think it's often just being ignorant to the facts of other people's experiences other than your own. And when you share the stories and you realize, wow, I had no idea that someone my age living in the same street as me, but just with a different skin color, would have a different journey to me based on that alone. And we need to tell that story, and we need to find out why, and we need to change the narrative of what's happening there.
Thank you for sharing that, Laura. That was powerful and very impactful. Dion, the question I have for you is, what are some things we can put in place to help our medical experts and folk in the healthcare arena really listen and have a compassionate ear for those coming in with rare disorders? What are some things we can put in place to help with that? Family faculty programs, what? Give us some ideas.
Well, Laura spoke about the research piece earlier. I'm a huge proponent of having Black people at the table when it comes to research. But with that, because you don't have the numbers, I'm not talking about globally because that's not my experience, but here in the United States, there's a huge mistrust with government, with the medical community. And so what I would like to see medical professionals do and researchers, when you're asking for someone to participate in your study for possibly having a new treatment on the horizon, don't just go to the community. You have to build trust first. And that's a huge thing. And I'm not quite sure how it could be done that way, but I also want medical professionals and institutions to understand that there needs to be a lot more community outreach, not in a specific treatment, but being able to be seen, making sure that if there is a community picnic going on, that you are sponsoring it, that you have people. So when it's time to ask people to do things for you, which is participate in your research, participate in this study. We're studying asthma. We need some people to treat this new Ewing sarcoma or test this Ewing sarcoma medicine that we have. They'll be more apt to help because they've seen the work that you've done in the community. It's just like all of us, especially those of us who are in the nonprofit space. people will latch onto you when they've seen the work that you do. They'll be more apt to help you. They'll be more apt to donate to your cause. It's the same thing in the medical community with medicine. If I am a Black woman and I live in an area that's not safe, but someone in my neighborhood created an outlet for children, and you can say, oh, that was really nice. Oh, yeah, such and such hospital sponsored the bouncy houses for this. Not that it has to be that, but there's trust needs to be built in order to get an exchange, a fair exchange, if you will. And I believe that if we get hospital executives to make sure that they have training for their the providers that are under that hospital umbrella, as well as medical schools, to make sure that at every step in their education, there needs to be a class on empathy, on active listening. I was in corporate America before I got sick, and I used to train people. Sometimes we would have people close their eyes and listen to all the sounds. We would play different things to have people actively listening to what the patient is saying versus the first 2 minutes. Oh, I'm having this symptom. Oh, well, it sounds like it's sinus. It's like, no, I've taken sinus medicine. That's not what this is. This is something else. And to have them trained to listen, but then to go the extra mile. Okay, I've listened to her. Now, what can we do to make her life, her quality of life better, or to get her cured, or at least treated to the point where her life is productive and she's satisfied. And so if we could get to that point, I think that would help tremendously, along with everything that Laura said.